Right. At this point, I'm very happy to bring in a new member to our Akron Rotary Club. The membership team has been very active despite the pandemic. And fellow Rotarians and guests, on behalf of the Rotary Club of Akron, it's my privilege to add a new member today. Please allow me to introduce, for membership, Michael Gallucci, proposed by Dan Reynolds. Michael, if we were in a real meeting, you would be stepping up to the podium right now, as you are beginning a great adventure in leadership, friendship, and service to your community with your invitation to join. The Rotary Club of Akron has accepted you as a person of good character, high ethical standards, a person who has a heart for service, and a person who will represent the classification of a community leader. We have invited you to become a part of this worldwide organization dedicated to encouraging and fostering the ideas of service above self. Dan would routinely present you our official Rotary name badge and the pin featuring the Rotary wheel, and you'll get that post-pandemic. It's the international symbol of Rotary, which we encourage you to wear proudly. Michael, you have been invited by Rotary to join Rotary, but it will be through your own actions that you become a true Rotarian. We encourage you to learn all you can about Rotary and to strengthen your own member leadership and communication skills by actively participating in the activities of this club, including attending weekly meetings, social events, whether they're virtual or not, and service projects. You will be provided many opportunities through this club and district to enhance and expand your professional and personal skills, and these opportunities will provide great value to you. You will also be provided with a number of opportunities to serve others through our service, vocational services, community service, as well as international opportunities. I invite you, fellow Rotarians, to freely give of your time to make Michael feel welcome and provide him with guidance and friendship. Fellow Rotarians, please help me welcome Michael Gallucci, our club and the world's newest Rotarian. Michael, would you mind giving a few words about yourself? Introduce yourself. You're on mute. There we go. Now you're off.
Am I good now?
You're good to go.
All right, great. Thank you. Well, first of all, it's a pleasure to be with all of you today. I wish we were together in a comfortable space and all having lunch, but that will come one day soon, I'm sure. But it's a pleasure for me to be joining your group, to be joining the Rotary International. I come to you through my activities at the Rotary camp, where Dan and Pam and so many others of us have served for a number of years. And it's through that activity that I come to you today and got involved with the camp probably, I don't know, 5 or 6 years ago, maybe a little longer. I've had the opportunity to work with the folks at the foundation on a number of initiatives that involve the camp. And so I think it's only natural that I take the next step and come and be part of this wonderful organization at the club, which really started all of these different branches that I have had the pleasure of serving with and for. So it's a pleasure to be here. I look forward to meeting all of you in person. Those of you who I don't know yet, look forward to getting together and meeting all of you at some point when we can do that safely.
Well, thank you very much, Michael, and welcome. And please don't hesitate to reach out if you're in need of connecting with somebody about some element of Rotary that you don't quite know about. They'll be reaching out to you from our mentorship team to assign a mentor as a guide as you navigate the fields of Rotary, because we know that the more active you become, the earlier you jump in, the more likely you are to have a good experience and to stick around. So thank you very much. So at this point, I have to confess that our speaker had a family emergency and had to fly out of Cleveland last night. So we will get Chef Rosh, who believes food is a journey, not a destination, will be back to meet with us the end of February. In the interim, I had been talking with Katie Miller last week about what are some things that's on people's mind. And clearly she said, well, we're pretty absorbed with COVID, what to expect. and what's the story with the vaccine? So we had kicked around, do we really want to have a whole speaker dedicated to that? Or do we want to have some small Q&A actions? So for those of you who are guests and may not know me, I am a pediatrician. I'm the chief medical officer at Akron Children's Hospital. And as part of that role, I have become to be I'm actually the incident commander. And along with my chief operating officer, we've been running all of COVID operations since last February, before it was absolutely in our area. And as I shared earlier, it's been quite a voyage. We started out with no information, that we were working with our best guesses. And then we had to quickly do PDSA, rapid improvement cycles, to change our operations and what we needed to do to keep our patients and families and employees safe. And now we've gotten to the point where we know what to do in the workforce, and we've not had employee to employee transmission inside the hospital. We know that congregate eating was a risk factor early on. So we keep everybody masked, socially distanced, and especially don't take a mask off when you're in a small enclosed space for more than 15 minutes if there's someone else in that room. So those are the things that have gotten us to this point. Remarkably, we have been blessed with the development of a vaccine, and actually 2 vaccines that have been released under emergency use authorization. So at this point in time, Akron Children's does not mandate COVID vaccine for our employees, but once it's FDA approved outside of the emergency use action, we may do that annually like we do our flu vaccine. Akron Children's got our first doses of vaccine for 1A employees, which are people that are in their course of their duties, whether they're physicians, nurses, techs, respiratory therapists, social workers, nutritionists, anybody who is patient-facing category falls into category 1A. And basically, we've taken a broad approach to that if people are in our admissions office and they're facing patients, because one of the things unique to pediatric hospitals is that children under 2 and children with special needs do not necessarily wear masks. And in fact, it's contraindicated for someone under 2 to wear that mask. So it's a safety issue issued by the American Academy of Pediatrics. Therefore, what you might think of as high risk in an adult hospital, you think of the COVID units or the intensive care unit or the ER. In pediatrics, it's probably just as high risk, if not higher, in the primary care offices, the urgent care offices, and the ER. So we started a rollout of the Moderna vaccine, and we started that the week before Christmas. We will be beginning our second vaccine round for the booster that has to happen for the Moderna vaccine 4 weeks after the primary vaccine. If you are in a queue in the community to get a Pfizer vaccine, you get your booster within 3 weeks. So I have been doing town halls and Q&A sessions in all of our networks here at the hospital with our some of our board members have asked for additional information about vaccine, questions about distribution from the state. And I have never proclaimed to be an infectious disease expert or necessarily a public health expert, although pediatricians are kind of bent to public health because of our commitment to vaccine and preventing diseases that occur later in life. Even if we don't get to see the benefits now, we have great delayed gratification, as do all of you Browns fans. So I wanted to use this opportunity that can be a Q&A, or if you want me to run through frequently asked questions, I can talk to you about how the vaccine was developed. I can talk to you about what are common fears about the vaccine, about the speed at which it was developed, and what were the steps that were routed and changed that allowed that to come to fruition safely and more rapidly than any prior vaccine, which was usually 2 to 4 years. But I would like to, since we've got about 20 minutes, I would love to have, if David Hall, if you can look at the question in the chat room, or if people have pressing questions, they can unmute and offer that up. And while we're waiting for that to come in, I will just talk a little bit about this vaccine. So the vaccine was developed in parallel between the Pfizer and the Moderna. And interestingly enough, they really look a lot alike. And if we weren't in a pandemic where we're not worried about giving credit, there may be some legal ramifications of the fact that these two novel vaccines were created along probably the same pathway. But we're just grateful that we have two vaccines that we can choose from. The way the vaccines work is in the vaccine is actually a dose of COVID mRNA, messenger RNA. So it doesn't mess with your gene, that's your DNA, and that's in the nucleus of all your cells. The messenger RNA lives in this space between the nucleus where your genes are and the outside of that cell. So we probably don't have time to go back into cell biology, but the nice thing about mRNA in this vaccine is it's designed, the piece of mRNA from the coronavirus actually codes for a spike on the surface of the vaccine. And then that gets into a few of our cells. Our body reads the mRNA and creates antibodies to that spike. And interestingly enough, and which is really a brilliant design, is over the course of several weeks to months, all the messenger RNA gets depleted, but we still have the memory of a reaction against the spike protein of the COVID virus, so that when we get exposed to natural occurring COVID, we already have antibodies made and we get a boost. And consequently, if you do get COVID, it will be very mild. There have been nobody in the trials that ended up hospitalized for COVID if they got the vaccine. If they didn't get the vaccine, they did end up hospitalized for the vaccine. So, or hospitalized by COVID. So that's really a remarkable study. The design of getting this to market early, people say, well, how do you cut out all that red? How do you cut out all those corners? Is this really safe? And really, rather than cutting corners, what they cut was red tape. So there's many processes in vaccine distribution that is either limited by the government or limited by the money that the vaccine producer has. So that instead of doing phase 1, phase 2, phase 3, phase 4 sequentially, that can take up to 4 years commonly, it could be done in parallel because there was a lot of money infused into these areas, some from commercial and some from the government. So it's not that the steps were skipped, it's that they were able to do it in parallel that really expedited it and removed all the legal paraphernalia that comes from developing any new drug. That's really, again, the word that I've started to dread because it's overused so much, is unprecedented, but this clearly is an unprecedented modality. Now, the piece that's not available is we've only got about 6 months worth of human data with these actual vaccines. So the trials are ongoing, so we will know if there are late side effects, but we really have not seen any significant untoward side effects as the vaccines are rolled out. So I was skeptical until I got better educated about this, about how it was developed and why it was able to go so fast. I don't think I ever shared to this group, but I thought, oh boy, as a leader, I'm going to have to model the way. Am I ready to do it? But I can tell you, I got my vaccine Christmas Eve, and I get my next vaccine on the 21st. And I think if you have the opportunity to get a vaccine, get a vaccine.
Dr. Rob, we got a couple questions here.
All right. Take it
Connor,
away.
I give you 30 seconds to ask your question.
What is that? Come on. Wow. No, my question was just kind of in general, I've heard some things, Dr. Rob, where the way that the UK is going about rolling out their vaccine is that they're trying to give as many people one dose as opposed to, getting people 2 doses. So can you speak at all to the rationale behind that? And I'm not sure if theirs is the Moderna or the Pfizer vaccine, but given that the Moderna one is 90% effective after the first dose, and the second dose brings it up to about 95%, at least my layperson perspective of it without knowing all the details. why wouldn't the US want to take a similar approach to provide at least some immunity to more, as opposed to 2 doses to a lesser number of people initially?
So that's an excellent question. And the number on the early trials was probably not quite 90%, Connor, but there was a good boost. Okay, so you have natural disease, you get an antibody response. When you got the first dose of the virus, of the vaccine, you got a response that was almost comparable to natural disease, but not quite. So there was a 90% response rate, but whether those antibodies got high enough to truly modify the disease, if you were, unfortunate enough to get the disease close after your vaccine, we don't know. So the CDC had authorized that for Moderna vaccine, 4 weeks later, you get your vaccine. 2 weeks after that, you're at your maximum protection. And that far exceeded natural disease. So again, you may get a quick fix with one vaccine. What we don't know is how long do those antibodies stay high and protective. And that's why the CDC kind of weighed in and said, well, let's mimic what the trials were, because both the Pfizer trial and the Moderna trial were using the 2-dose regimen. So as long as we don't have a problem with production of the vaccine, the CDC has made the recommendations, and Akron Children has stuck with that we're going to 2-dose. Now, there may be 2 years from now, we'll say, you know what, we could do this with 1 vaccine, 1 dose. But by then, we'll have enough people with immunity that the prevalence of the disease is going to be a lot less, and we'll be in better shape. That's a great question.
I knew there had to be more to it, so thank you from the expert. Thank you.
And
Dr.
Steve
Rob?
Bowie, yeah, go ahead.
We got another question here in regards to, is there a schedule for the general public? And second part to that is are you able to choose which vaccine you get?
So I'll answer the second one first, because that's easy. At least today, you are not able to choose, because at least in the healthcare organizations, you get one or the other. And we don't have a voice in it. We get our Moderna vaccine, and we're grateful to have it. Early on, I might have grabbed for Pfizer just because I know that name and because I could get my second dose in 3 weeks. But I really think we're talking about an ultra marathon, not a sprint. So I'm not sure that 1 week matters. The rollout in Ohio is really supposed to begin next week. Organizations had to apply to become a 1B vaccinator. So Akron Children is a 1A vaccinator. We did make application early on that we would be willing to accommodate the general population, or specifically we were interested in our older patients that are 18 to 25 that are especially vulnerable and at high risk, or our connection in the school health mode. We have multiple school districts across the state, and we do provide the nursing care in those schools where it would be pretty easy for us to mobilize a team to vaccinate the school teachers. So that was our motivation. We were asked yesterday to commit to giving it today, if the need be. And regretfully, I don't have the capacity right now to say we could go live tomorrow. And that's what the governor wants. So we estimate that there will be 900 centers across Ohio that will be live, and they will receive vaccine on Thursday and will be expected to give it within 24 hours, which I can tell you the logistics of lining up people, even that are motivated, people that really want it and would wait in line, just reaching them, getting them registered and getting them here. 24 hours is a pretty lofty goal. But the way it's supposed to roll out in Ohio is starting tomorrow, it would be people associated with schools and those of us over 80. And then every week that passes, we'll subtract 5 years from that age. So if you're 65, your number would come up probably in mid-February. And that would be to get the vaccine in these local sites, these 900 sites. Now, whether they'll expand from 900, they had 1,800 organizations that applied. Only 900 said we could flip a switch tomorrow. Most of us are prepared to do it, but it will take about 2 weeks so that we have to have registration, because when you give it to the public, you have to have unlike my employees where I can just give it and keep a record of it, with people that are from outside the organization, we have to go through the laborious stuff, just like when you register for a doctor's appointment or a physical therapy appointment, and requires, you know, information about your insurance and whatnot. But again, the vaccine should be free for any kind of insurance. The only thing you may be charged is a vaccine administration fee, which is anywhere from, you know, depending on where you are. I've seen estimates of $20 to $120, but there's nothing else that's exorbitant. When you get your first vaccine, if you get Pfizer, your second vaccine will be scheduled and you'll get Pfizer. If you got Moderna, your second vaccine is scheduled and you will get Moderna. So I hope that answered that question.
Yeah, I think they answered that question and a few others. So I have another question though, in regards to getting information with our diverse population in North Akron and some other areas. Are there efforts being made by the CDC to translate the information regarding COVID into different languages?
Boy, that's a great question. I know that there's Spanish easily accessible. I know that here at Akron Children's, we have a large population from the Hill in some of our primary care sites. And we have done one-offs on our own because we were not able to find it early on to use all the languages that go to our North High School. So again, I would start with the hashtagging this together Ohio website, the state website, or the cdc.gov website. But I admit I do not know the current status of it. I know 3 months ago we really had limited things, so we had to invest in translating anything we were doing, including even our mask signs. We did that ourselves.
Very good. Another question regarding the vaccine and kind of related to Connor's question, but will the vaccines, to your knowledge, have any response or effect on mutations of the virus?
That's an outstanding question. And as you all know, in the UK and early on in South Africa, there were found to be mutants. And those shifts that happen still expose the spike protein that is the basis of the Moderna and the Pfizer vaccine. And it's believed that the early studies so far show that the vaccine is efficacious, again, because it's really focused on the spike, and there is enough similarity of the spike of the mutants to the spike of the COVID virus that the vaccine was manufactured for. There is a risk, though, with all these SARS-CoV-2 vaccines or germs, that mRNA viruses are very prone to mutating. And that's what happened early on when we were really braced for a pandemic that stopped in Toronto, because the vaccine or the virus mutated and was no longer deadly. So that's why when we were starting the SARS-2 or the SARS vaccines, we ended up not having to do it. And that was another reason why we got a jump start on these mRNA vaccines, is because there was already a lot of work done for SARS until it mutated and no longer found a host. So I anticipate that down the road we will have mutants that don't have that spike protein as a responder. And I would not be surprised if we don't have other vaccines with other mechanisms that need to be developed over time.
Okay, very good. Another question here in regards to, if you've already had the virus, will your antibodies in your system act as a good protection?
So there's two parts to that question, if I'm anticipating this right. One, if you have the virus, can you get it again? And the answer, unfortunately, is yes, although I can tell you anecdotally at Akron Children's, we have 2 patients that we're pretty confident got COVID twice. One was an infant that got it right at the very beginning, and then when he turned 6 months old, he got symptomatic, sick again, and shed the virus one more time. And we had one other patient. That patient was not immune competent. So that may not be the normal, but that's what we've seen. So there's some evidence, not phenomenal evidence, that you get it twice. We do know that the amount of titer rise, the amount of antibodies that you get from natural vaccine or from natural virus is not as high as the second dose of vaccine. So the evidence is that if you've had the virus, you have some immunity, but it's still recommended that once you're 10 to 14 days out from that initial infection, if you're due for your vaccine, get your vaccine, and that it won't interfere. You may not have quite the same rise because you might already have antibodies. The good news is the first vaccine seems to be a relative freebie as far as side effects, both with Moderna and with the Pfizer vaccine. And because you get a sore arm, maybe a little bit of muscle aches. I think we've had a couple of employees after we've given over 3,000 vaccines. Well, we've not had anything more than that. We've had no one who had to call off work because they had side effects. When you get the second vaccine, if you are under 60, your vaccine complication rate goes up, but again, it's moderate. So I have some of the numbers here. If we compare, the best trials look at vaccine versus what's called a placebo, or essentially a saline. I'm giving you an inert shot, so you don't know which one you got. If we look at the side effects from this Moderna vaccine versus placebo, fatigue happened in 37% of the vaccine recipients, 27% of placebos still got fatigue after the vaccine. So again, it's power of suggestions. You get a shot, you feel side effects, but how much of that is from the vaccine? Headache, 33 for the vaccine dose one, placebo, 14%. Muscle pain, 22% vaccine, 14 in placebo. Chills, 8% in vaccine, 6% in placebo. Not really different. Joint pain was a little higher at 17% versus 12. Fever, 1% versus 0.3 in placebo. Nausea and vomiting, 8 and 7%. So again, first vaccine, free pass for the most part. Second vaccine, if you're under 60, it's a little worse than that's the first time. I'm happy to say I'm over 60 because we get less of a immunogenic response or a reactive response. The second dose fatigue is 65%, headache 59%, muscle pain 58%, chills 44, joint pain 43, fever 16, nausea and vomiting 19. So again, the second dose, you may actually need to take a day off work because you feel crummy, not because you're contagious. There is no part of this vaccine that is a live virus. If you get the COVID vaccine, it cannot cause COVID. Now, I have had employees who got the COVID vaccine. 2 days later, they got exposed to COVID, and they did get a case of COVID that fortunately wasn't severe. And again, that's HIPAA information I should know, but because of where I sit with the incident command, all this stuff gets reported to me. So if you work at Akron Children's, I may know your business, but I promise I will keep it de-identified. But that's what we've seen so far. And I think the same is with the Pfizer. My daughter is an OBGYN, the one that just gave birth to my grandson like 8 weeks ago. She's not yet back to work, but they vaccinated her. Her second vaccine was yesterday. She had a day with fever, muscle aches, and a bad headache that might have gotten in the way of her going to work. Her husband gets his second vaccine. He's an infectious disease doc at UPMC in Pittsburgh. So he got his second vaccine today. I'll get his report later tonight. Other questions?
So for those that have compromised immune systems, they've been advised against Pfizer. Is there any way you can be directed to Moderna? Or what's your advice for people regarding, having immune issues?
Yeah, I think what you need to find out is where your if you know that you're not supposed to get Pfizer because your doc says don't get it, or you're on antibody treatment for something else and the timing isn't right, when you sign up for your vaccine, they should be able to tell you what they're giving today. So if you sign up at SUMA for the 1B, they ought to be able to tell you. And if it's not what you're supposed to take, then you can call another site of those 900. Most immune compromised patients have not been redirected, to my understanding, to get one vaccine specific or another, because again, the mechanism is the same, but again, there may be some additional information I'm just not aware of. All right, we are at 1 o'clock, and I will close the meeting. And I thank everybody for coming, and enjoy the Afterglow Browns fans. We are adjourned.
Hey,
Great
Dr.
info.
Rob.
Oh, go ahead, Dave.
Oh, I was just going to say, I know you talked a little bit about it, but if you don't mind talking about yourself, did you have any side effects from taking the vaccine?
Yeah, if you've had an adult tetanus booster, or if you ever got the DTaP, the one that has the pertussis, so that you don't give your grandkid pertussis, I had a worse reaction from that than I did from this one. My arm was sore about 5 hours after the shot. And that night when I rolled over in bed, I didn't want to roll over on my left arm. But the next day I could use my arm if I pushed where the shot wasn't hurt. And by the next day, there was nothing. When you sign up for a shot, at least when we did it at the hospital, there is a CDC website that you can volunteer to participate in, and they would contact you daily and say, did you have any of XYZ? They're putting together that database. So I did participate in that for the first 2 weeks after my vaccine.
Very good.
Somebody else described it, Dr. McGregor, to being, if you've had a shingles shot, to being similar to that as well. So if you haven't had a tetanus, but you've had a shingles, they said the arm gets just as sore or sorer. Don't know if you've heard that or not.
No, I haven't. Actually, the second shingles vaccine, the one that's I can't remember the name of it, Shingle Rix or something,
Right.
that you get when you're over 60, that one's the worst. That was the worst.
Yeah, I had to have that one, even though I was under 60. So,
Dr. Rob, what would be your best? I know there's estimates out there, and it's going to depend on a lot of things, but what would you say your best guess would be for folks that are not considered at risk for, in any other way, and that don't qualify for some of the initial criteria? Would you say summer's probably the earliest, or do you think it's going to be into the fall that someone would be able to get the vaccine?
I think probably in the summer. Again, it depends on the supply and demand, the production, and the challenge that I see from a public health perspective is that there wasn't a master plan. So the states are all reinventing the wheel, and some states are more efficient and organized. But we don't know the distribution sites until today of those 900, and how each of those distribution sites is doing their vaccine was up to their own organizations. So again, I don't think there's anything risky about it. I just don't think it's as efficient. If we were going to do a mass vaccination, if I asked Donna Skota, our own Donna Skota, to do a mass vaccination, she would do something at the Knight Center or at a large convention center and take all comers. Now, when we do this sequential rollout, I understand the logistics of it, but until we get 70% or 80% of our Ohioans immunized or over COVID safely, we're not going to be able to go back to normal with our masking and our social distancing. So again, I got the vaccine, I'll get my second vaccine. I can't pretend that I'm invincible or that I'm not at risk, because what we don't know, we know that if I get 2 vaccines, I have an 85% chance that I'm pretty protected and I won't get sick or I won't get very sick. What we don't know, and that data should come out over the next several months, is that if I get exposed and I don't get sick, can I still be colonized and infected and take it home and give it to my immune compromised wife? That's the piece, that's the ticket. And I will tell you, everybody wants to be done with this, and we all want to be back to normal. Even, even some of my chairs of my departments, the docs that are the most experienced doctors said, Rob, I feel a lot more comfortable flying an airplane now. And I said, you had one vaccine a week ago. You can't feel comfortable. That's false. And that's going to get you into trouble. When you start to be, you know what, we're all immunized. This is no big deal. You let your guard down, and you fought this so long. We would not want to take this home to your elderly relative because you think you're invincible. Having said that, again, when I have 2 vaccines and 14 days after that one, am I going to take my mask off and go running into a crowded bar? Absolutely not. Will I feel a little less nervous when someone at the grocery store doesn't have their mask over their nose? Yeah, probably. I don't know if that's science or psychology, but.
Dr. Rob, I have a question if you don't mind. By the way,
Yeah.
Fantastic presentation. In my previous life, I was a biochemist actually, and did quite a bit of work in research for cancer research. And of course, the messenger RNA has been around for several years now in regard to the potential that it has in, immunotherapy for cancer patients. The difficulty with those types of therapies, at least when I was immersed in it and studying it, my colleague was doing so, was the targeting. The messenger RNA is very fragile, right? And so it degrades very rapidly because it's not the double helix. So the issue was more how do you target specific cells within the body so that it was taken up by the right cells. And the other issue was because the delivery system had to be kind of a lipophilic. It was suspended in this lipophilic, liposomes, droplets for the injection. It was the difficulty wasn't necessarily triggering immune response, right? The difficulty was making sure that you didn't have an over response so that you could shut the immune response down and you wouldn't have too aggressive of a response. Are you aware of how maybe Moderna or Pfizer or some of these new technologies have addressed those issues in terms of the long-term safety of being able to either target the correct cells and or to shut down because one of my colleagues just, was like, well, you don't know long-term, a 6-month study is a good study, but what happens if you have these lipophilic delivery systems lodged in fatty tissue somewhere in the body, and then it gets dislodged at a later date, and then you trigger another immune response that's then too aggressive. So those issues, that could be very granular in terms of a question.
No, that's a sophisticated, excellent question, Dan. So my understanding of this, I'm an expert because I've been at the right place at the right time, not because this is, I'm a hospitalist, diagnostic dilemma doctor. That's kind of what I do for kids. So I've been surrounded myself by a lot of smart infectious disease folks and immunologists. So my understanding is with this vaccine, whether I don't believe it was targeted to go to the lympho-reticular system, but that's the reality of it. That seems to be where the uptick is, the largest percentage of cells, and it is delivered with a lipid droplet. So that lipid droplet, for those of you, it's a fatty droplet. For those of you who may not have the biochemical background that Dan mentioned, and that fatty droplet allows this mRNA particle to lay on the top of a cell membrane and then get into the cell. Okay, it doesn't get into the nucleus, it gets into the cell. So if it gets into fatty cells, Dan's alluding to the fact that things can sit in fat for a long time. And the worry was made early on that, that immune response down the road may now be attacking your joints like arthritis, rheumatoid arthritis, or another autoimmune disease. And that is a reality, Dan, but I will tell you, autoimmune diseases aren't very common in children, yet natural COVID has caused lots of autoimmune diseases in our kids already. And fortunately, we said early on, kids don't usually get hospitalized with COVID. They don't get hospitalized on purpose with COVID. Many of them get hospitalized and we find they do have it. But now we're finding that from the COVID itself, the multiple systemic inflammatory syndrome, MISC is what you'll see it advertised, looks a whole lot like a disease that back when I was training was a relatively new disease called Kawasaki, that is probably viral induced reaction in multiple systems. And the treatment is the same with IVIG, immunoglobulin, to block the antibodies in response. So, again, do I know for sure that I'm not going to get lupus 3 years from now? No, I don't. But I do know if I get COVID, I'm over 60 with asthma and hypertension. I not only do I not want to spread it to any of you all or to my wife, I don't want to die from this. And I know, unfortunately, I have a college roommate that died from this. One of my best friends here at work's brother died the first week of COVID. Suma, again, we have a lot of community calls. And, I would say, Rob, you're using anecdotal medicine. You're not using numbers, but we don't have those numbers right now. But I know there was a healthy 38-year-old young man athlete who got this at one of our local hospitals and died. So again, it's all relative risk, Dan. If I didn't have to take it, if you said, oh, there's this novel virus coming by in 5 years, do you want to be first on the block? I'd say no. But in this situation, I think that I'm willing to take my chances, knowing there are some theoretical issues of long-term side effects. Again, we're out 6 months. If we're out a year, I think it's even less likely. If we're out 2 years, it's probably a lot less likely, but it's not zero.
That being the case, when it is accessible, for teenage children, I call them children, right? But my kids are college bound. Is that, given that demographic has less seems to have less risk factors for the virus, where do you stand on them, taking the vaccine, given that, they may be in childbearing years and that sort of thing?
So the Pfizer vaccine was tested for older teens, I think 16 and above. Moderna was not tested for teens. So I can't give Moderna to my teens unless they give special dispensation with the 1B classification because they have an immune deficiency or something like that. My kids are in their 30s. All are in healthcare, so everybody's gotten it. Everybody's gotten their first dose, and I'm hoping they're both my daughters are both very prolific and give me lots of grandkids. I don't have any qualms about that in the short term. The evidence of giving it, evidence of getting COVID when you're pregnant, just like getting a bad case of the flu when you're pregnant, you're sicker. And pregnancy does increase your risk of a bad outcome with flu or with COVID. But keeping you from getting pregnant or impacting that, there's a lot of stuff on the Not Real News Network and the social media about fertility, and I don't know where that comes from. I mean, I'm extrapolating that maybe because RNA sounds like DNA and DNA is my genes and I don't like genetically modified foods. I don't know if that's the stretch people have made, but there is no data on fertility. Again, do we have enough rates? I will share anecdotally that my oldest daughter was doing artificial insemination. She had trouble conceiving and her time was up on St. Patrick's Day. So I said, really, in the middle of a pandemic, you want to get this done? Of course, she's an OB and she knows a lot more about OB than her dad. And she doesn't hesitate to tell me that and enjoy every minute of it. But, so she was able to have implantation and carried successfully to term. And little CJ had his 2-month-old checkup yesterday and gained 3 pounds in the last month. So again, you know, I hear your concern. I think if your kids get sick, they're probably not going to get as sick, but they may bring it home to you. And you know what? You look like a pretty healthy guy. Obesity is probably the biggest risk for adult comorbid features that makes a worse outcome. So it doesn't look like you have that on your side, Dan. But again, if you have an elderly parent or another relative, you know, those kids can still be vectors. So are you protecting them for public health and putting them at risk? Oh, maybe. But I think in the middle of a pandemic like this, I land on the public health side. But again, that's not politically motivated. That's just the science geek in me. And you probably have a little bit of that in you too.
I do. It's a very interesting discussion. I definitely lean towards your take on everything. I just the one colleague that I spoke with was just like, you know, the biggest thing for him was the fatty tissue and the, you know, it would be a non-issue if you get your immune response and the rest of it is processed and you can determine that it's excreted, you know, it goes through the liver and it's excreted. He's like, I'd be first in line, but you know, we don't know if it's lodging in fatty tissues. Gave him pause.
But the reality, if you think about your work with mRNA, and I'm sorry guys to get this geek,
I love
but
this.
I don't get to talk to geeks that often. Don't yell at me because I didn't give them the vaccine yet. But mRNA is fragile, and mRNA there's estimates, and again I don't remember the original studies, but like say just 20% of your cells take this up. Again, if they code for that protein, it's a single protein that we think that's targeted. It's for that spike. So it's an antibody against that protein that you generate yourself, and that mRNA that dies out. So, you know, years from now, you will respond and you can have antibodies, but it's not like you have any mRNA to keep stimulating your immune system. So it's only your amnestic, you know, T and B cell response. Any other? This is more than you wanted for, and I apologize. I would have gotten a real expert in to talk to us, but when she canceled this morning, and I thought I can't get a hold of anybody at this short notice, I'm gonna go with my life work for the last 9 months.
Dr. Rob, before you leave, you hear and read about these injections being 95% effective. What does that mean for the other 5%?
That means it's not effective or not effective enough to say this is better than natural disease. So again, you and I, John, of everybody on this call, we're probably we're probably not going to get as vigorous a response to the vaccine. The older you get, the less, you know, the more tolerant your immune system is of other things. But so if it's 85 out of 100 people wouldn't get the disease if it was 85% effective, but there's still maybe 15% that may get disease. We don't know if it's modified disease or not. So, you know, again, most vaccines, I'd say most flu vaccines are probably about, maybe in a good year, 60% effective, 50% effective. So this one, out of the gates, most of them are 95%. But for us, for me, it's probably closer to 85, maybe 90. So it's not, and that's another reason why you can't let your guard down, John. And other than when you're in the swimming pool, don't have your face uncovered for a while yet until we find out that the virus has no vector in North America. You know, if enough people get immune, then the virus doesn't have an ability to continue to spread. And then we can be back to giving you high fives and bro hugs at the meeting.
Thank you.
The technology with this is just really exciting, you know, for a scientist. However, do you envision if we do get into a situation whereby the virus begins to mutate and this will make us more nimble to create yet another vaccine, right? But at the same time, do those new vaccines, do they act similarly to a traditional flu vaccine where the new strain comes out and that following year, you're able to produce a vaccine without going through the same FDA hurdles? Is this a kind of a similar circumstance whereby you feel that we'll be very nimble to be able to address mutant?
I think we will be nimble, but Dan, I fear that the Moderna, the current mRNA technology is really latched to a single target. And as soon as a mutant exists that doesn't have, like, we can't, our body no longer recognizes their spikes. Their spikes are different than their cousin spikes were. Then we need another direction. And there are other vaccines that are approaching this differently. I have to confess, though, I stopped reading about them when these two got on EUA, and I said, I'm going to know the ones that I'm going to be able to use, and then I'll backtrack. But I think we're going to be challenged to keep working on this from a different approach. I have a friend that works at the NIH who I only hear at Christmas and weddings, but she reached out yesterday, and she's actually, this is what she's doing right now in DC. She is studying all the isolates, or a percentage of the isolates, to try to get ahead of detecting any that would be resistant. And so far in the US, we haven't. I believe there was one in South Africa that does seem to have stepped out of our vaccine, but that's the only place I know so far.